Welcome to the next episode of Mic'd Up a Chiro Up. You've got Tim and Brandon today. Tim, say hi.
Hello.
I'm excited to have you back on the podcast.
Well, I couldn't be more excited to be here.
I finally gave you the right time and date. Just a reminder, if you haven't yet, hit a follow button and share this episode with a friend. It really does help us reach more great DCs just like yourself. Today's going to be a good one. Today we're going to talk about oversized display booths. We're going to talk about research that may have you rethink the way you treat dizziness. And most important, the biggest piece of the entire podcast, Cankles.
Well, that sounds like we're off to a good start. So before everybody tunes out, do you want to give us a little better intro teaser?
I know what you're thinking. I guess I can guess what the people listening are thinking. You know, these topics may sound a little unusual at first, but trust me, there's going to be a lot more to this conversation than meets the eye. We're going to uncover some insights that really could enhance your practice, engage your patients in new ways. Stick around. This podcast is going to deliver some valuable perspectives I don't want you to miss, because it's going to start off with the display booth presentation, and I want to talk about something special. And really, this month, 10 years ago, was the first time we started selling Chiro Up. So September 14, we finally got the entire program done. Version 1 was out. A month later, Tim and I went on I don't know, how far is Indianapolis?
World tour.
Yeah, world tour.
Indianapolis.
Let's call it a 4-hour drive. 4-hour drive to Indianapolis, and we went to our first talk, which we were speaking, and we also had a booth, and we welcomed our first subscriber, Dr. Adam Osenga.
That first booth, we had this huge booth that weighed several hundred pounds. We had put it together ourselves. You had to bolt it together, the backdrop. We had our clunky computers and probably this 50-inch monitor, which at that time weighed, somewhere near 712 pounds. We had to have a bracket made for it that hung over the top. So it took us, all day to get this booth. Now everything gets shipped out in a 50-pound box and set up in 2 minutes. And we worked the booth as well. Not only did we provide the CE, but then we'd go to the booth in between to talk to potential subscribers. It was our first time. We were just learning. And I remember you were at the booth talking to Dr. Osenga, and so it was time for us to roll again. I went up on stage. I had to cover your part that you were supposed to be doing at that point, whatever we were talking about, I think shoulder, rotator cuff issues. And about 5 minutes into it, as I'm struggling through your content, you hand me a piece of paper that said first sale. And then it was didn't just say first sale on this 8.5 by 11 piece of paper that was scribbled in Sharpie marker. There was a term of endearment right after that, which would be a female dog or wolf or fox. So you can probably figure that out. That was really nice. It's still framed and hanging in our office today.
That was one of the coolest things, is that I really... it was just gratifying that when you spend that much time and energy and money putting something together, that someone else saw your vision. They saw what you were trying to do, and they wanted to be a part of it. So it was really kind of an aha moment that I still remember to this day. I think that the biggest surprise moment of the entire weekend was when I was getting out of the car and I had a suit that had never been worn together, still had the tags on it, that I had never tried on. And you were a little worried.
I was. I was concerned the cuffs were probably not hemmed yet.
But at the end of the day, after all these years, especially at the beginning with doing presentations for 8, 12-hour presentations, working the booth during those entire weekends, I can say that gratifying feeling is still there, that people still see our mission and still want to buy what we're selling.
Yeah, from that humble beginning to the humble spot that we're at now with over 3,000 providers in 18 countries. And this isn't just a product. This is a mission. This is something that we've been passionate about from the start. That so many of our subscribers say the same thing, that when we show it to them, they said, I thought about that. And really, we wish one of you would have done this. It would have saved us some time. We'd had a lot more golf time in the past decade. But we thought about that as well, and we thought about your input, and we've used your input, and that's why Chiro Up has gotten to the point that it has. It's not because of that initial product that Brandon and I sold to some trusting subscribers. It's about what you helped us build, that this is a mission, and we're a team, and we're doing it together. So let's jump into the clinical portion of the blog. As always, I generally have no idea what we're going to talk about. Brandon hands me an outline scribbled in crayon, in 2 different color crayons, about 5 minutes before we sit down. And I have to say today, you really had me at Cankles. I didn't see that one coming. What are we going to talk about?
Yes, I said Cankles. Cankles, I guess I don't know the exact definition of Cankles, just the version I learned in high school. Just kind of when your legs and ankles appear as one, essentially. But essentially, I was at a soccer sideline. I was hanging out down there, and one of the kids had been hurt for a while. And I noticed that he had Cankles. And so kind of asked Johnny about what's going on. He's like, I got some repetitive ankle sprains. I keep on injuring my lateral ankle. And so it had been taped. They've been doing some rehab, and it just wasn't really getting better. And so we kind of looked at it, put them up on the table, and I was really looking at a syndesmotic ankle sprain or a high ankle sprain. This is when you have damage to ligaments and tissues that hold the tibia and fibula together at the ankle mortise joint, so essentially creating the ankle mortise joint, which is not a lateral ankle sprain. Now, lateral ankle sprains are the most common, so there's no question about that. However, these high ankle sprains are very few. About 10% of all ankle sprains are high ankle sprains. However, when you can assess these things and you can manage these things and treat them, we can take these very long recovery periods and we can shorten them significantly. And I hope we can shed some light on that today.
Yeah, so the first step is saying, well, how do we diagnose this? We need to narrow that because there are a lot of possibilities that any time a kid has a swollen ankle or any patient has a swollen ankle that came on potentially traumatically, we want to rule out fracture, those signs of a lot of swelling, especially rapid swelling, discoloration that develops more and more in the days that follow, and the inability to bear weight. In fact, that inability to bear weight helps us with the Ottawa ankle rules. That's a set of rules that can rule out fractures with 99% accuracy. And I know we're going to dive into that just a little bit later, so hang on for that. We also want to rule out other potential sprains. It may not be just the high ankle sprain. It may be a lateral ankle sprain, which represents the majority of those, especially that anterior talofibular ligament. And it's because of the mechanism of injury that when a patient has their ankle rolled inward, that it inverts and plantar flexes, we have a lateral ankle sprain. And then we could also have a medial ankle sprain of the deltoid ligament. Now, that's a tough, robust ligament. It's not sprained nearly as easily. It would be the second most common. And then the third most common would be what we talk about now, high ankle sprains, meaning that piece of cellophane that holds the tibia and fibula together all the way up has been ripped.
And I like this diagnosis for this podcast because a lot of times you and I will see patients after they've tried everything else. And this is one of those diagnoses that if it's not managed and assessed properly, it may turn into one of those patients like, hey, I'm just not getting rid of this problem. So we can, of course, use the orthopedic tests and the treatments that we're going to talk about to manage these patients. However, why the high ankle? And that's really the question that I try to get out of the patient when I first see them. And it really comes down to the mechanism of injury. So we can, through different sports and hobbies and habits and actions and traumas, we're going to exploit different anatomy. And what this is going to turn into is if we can understand the anatomy of the ankle, we can understand how this happened and then, of course, how to treat it. If you think about the ankle mortise joint as a fairly unstable joint, meaning just the bones, because you have a slightly concave tibia, you have a slightly convex fibula, and it's resting on a flat bone called the talus. It's not a very stable joint like you would assume the hip would be. But fortunately, we have some ligaments in there. So we have the anterior tibiofibular ligament, which is the most common ligament that's going to be sprained in a lateral ankle sprain. You have the posterior tibiofibular ligament. Not often is that one sprained. And then, of course, what we're going to talk to today is the interosseous membrane, and we're going to focus on that one and not really focus on the lateral one today. So the interosseous membrane connects the medial aspect of the tibia and the fibula along their entire length. However, the distal part is what most often gets injured in these kinds of injuries. Now, at the very bottom of the interosseous membrane, we have a fibrotic thickening, and this is where you're going to get a lot of tearing if you do, injure this significantly. And if that, unfortunately, is torn or sprained, we have an unstable joint. So the primary function of these ligaments is, and this membrane essentially going between the tibia and fibula, is to hold the fibula and hold the tibia together. And unfortunately, if they don't work very well, this is where we're going to have a lot of problems, because during normal ankle dorsiflexion and just normal range of motion, you're going to get spreading of that tibia and fibula by 1 to 2 millimeters. Also, if you're doing kind of jumping or landing on your foot, you're also going to get that membrane to separate. But fortunately, when it's intact, it springs back together, and now you have a nice stable ankle mortise joint. So let's remember this and what the purpose of this interosseous membrane is as we dive into what happens when we injure it.
Yeah, so how does this happen? Who gets this? If you imagine that your talus has been replaced by a wedge, like a splitting wedge for a piece of wood, take out your talus, slide the splitting wedge in from the front toward the back so that it's pointing backwards. That's wedge shaped, just like the talus. And if you take the front of that wedge and pull it up, it's going to wedge the tibia and the fibula apart. So syndesmotic injuries occur with ankle hyperdorsiflexion, especially if you add some external rotation. So when the fibula gets pushed laterally and that talus gets pushed into hyperdorsiflexion, the syndesmosis spreads. How does that happen? Especially collision sports, football, hockey, soccer. And one thing to remember is that in these traumatic type injuries, the mechanism of injury is essential because we know how syndesmotic injuries happen. We compare that to how a lateral ankle sprain would happen. It's the exact opposite. That in a lateral ankle sprain, oftentimes we have plantar flexion and inversion where the ankle rolls inward. Versus a syndesmotic sprain, we have dorsiflexion and eversion. So imagine that your cleats are stuck on the turf. You're getting to cut medially, you get tackled from behind, your foot's caught on the ground, and now your foot travels up through this damaging range of motion in dorsiflexion and external rotation. And this often happens after other ligaments have been disrupted, either acutely because it was significant trauma, but more commonly they were disrupted chronically in the medial and lateral ankle. They weren't providing the support that was needed, and now the syndesmosis tries to support the ankle for those force, and it doesn't work.
You know, one of the things that we'll see is that with any kind of external rotation and dorsiflexion, we can actually get a proximal fibular fracture. Do you want to go ahead and, do you remember what that's called? Remember part 4 boards?
Yeah, the M fracture.
Mason-Neuve fracture, something like that. But one interesting piece about that I do want to highlight is that if you do have a fibular fracture, you can actually still bear weight. So just something to think about. These will usually be in the proximal third of the fibula. But let's go through the characteristic symptoms that our patients are going to have when they have a high ankle sprain. Obviously, we're going to have pain just above the ankle. That's going to be the big one. They're going to have the inability to stand or walk. So something else to think about. You know, any kind of dorsiflexion or external rotation of the foot, whether it's passive or active, will intensify symptoms. And with any kind of tissue injury, we can get bruising and swelling. This is usually pretty fast. There's not a lot of meat in this area, so you'll see those effects pretty quickly. Posterior and anterior shear tests, like we would normally do on an ankle sprain, are going to be negative, which is one of those surprising things. You're like, oh, I thought you'd have an ankle sprain as far as the lateral component, and it's not.
Yeah, unless, of course, you've had a compound injury that damaged the medial and lateral ankle ligaments. A lot of times these are so traumatic forces that everything starts to go. So we may have a concurrent injury, but a sole ankle sprain, absolutely. There's not going to be much stress going into inversion, eversion.
Yeah, and with those traumatic ones, always make sure you check for neurovascular compromise. You know, any kind of numbness, paresthesia, a cold foot, those are signs of a significant injury. Now, filling a compartment, and unfortunately, those nerves don't have compliance for that. Now, as for ortho testing, what do we do to make this diagnosis? So I use a syndesmotic tenderness length test, which is essentially breaking out a ruler. And all we're doing is looking along the area of the lateral malleolus and tracking upward and then along the medial malleolus and seeing how far up is this tender. And as you would imagine, the greater length of injury, the more centimeters of tenderness, the more significant the injury.
You promised there was going to be no math, and it's already failed. The orthopedic testing for this is just what you said, really. It's the same as orthopedic testing for any structure. One of the things that we talk about all the time is that every orthopedic test does one of three things. It either pushes on the tissue, pulls on the tissue, or makes the tissue work. So you pushed on the tissue. The next thing we do is we're going to pull on the tissue, some range of motion testing. It's going to hurt when you drive that wedge upward and spread the tibia and fibula. In fact, the test is called the passive external rotation test. So the external rotation test means that you're going to take the ankle, you're going to dorsiflex it, and then slightly externally rotate it. That combination spreads the syndesmosis, and the patient's not going to appreciate that. In the last one, to make it work, or maybe help it work, in this case, we're going to wrap the ankle, the distal ankle, down by the tibia and fibula, just above the malleoli. And if the patient has pain when they walk in general, when they stand, they toe raise, they heel raise, they squat, they jump, and you wrap it and the pain gets better, it tells us that the syndesmosis is probably one of the culprits.
This is what we did. So this was the test that we did on the sideline, is just to take some athletic tape, wrap fairly tight, not too tight. He could still feel his foot. And his pain immediately got better. I mean, he wanted to go in and play that day. We still held him off for that game. However, that was a key thing that I was like, oh my gosh, we just have the wrong diagnosis. Now, before we get into the treatment and before we get into the imaging, I want to take a moment to make a special announcement and express my heartfelt gratitude to you, our subscriber, and our incredible community. At ChiroUp, our story has always been driven by one thing: helping doctors like yourself. What began as a simple idea to provide better tools to chiropractors has grown into a thriving community of thousands of top-notch practitioners. Over the past decade, we've faced challenges, we've embraced innovations, and we have stayed focused on one goal: empowering you with the best evidence-based resource available. None of this would have been possible without your trust, your feedback, and ongoing support. You've shaped ChiroUp in every single way. As many of you know, we've been rolling out our brand new EHR to early adopters, and the feedback has been nothing short of amazing. The EHR is constantly evolving with new features and new updates added every single week based on the recommendations of these early users. So when it's your turn to migrate, you'll be stepping into an EHR that's been tested, refined, and successfully integrated into clinics of all shapes and sizes. Now for the special announcement. As a small way of saying thank you for the incredible support we've received over the last decade, we have something special for you, our subscriber. If you're already a ChiroUp subscriber, or if you join us by January 1st, you will receive an ongoing 25% discount when it's your time for migration into the new EHR. It's our way of expressing gratitude for your unwavering support. If you want to learn more about the new HR and the new rollout plan, please follow chiroup.com/EHR. Together, we've built something truly remarkable. And for the best part, we're just getting started. Thank you for being part of this journey with us. So getting back into the ankle, I think that we talked about the test where you tape the distal tib and fib, and looking for the possibility of a high ankle sprain. Really, what we want to do with this is to avoid imaging. One, it's a treatment, but also I'm saying, hey, can we avoid the imaging? And one, I can use that test, but also I look at the Ottawa ankle rules. They're a well-established standard for determining the need for any kind of radiographs following a trauma. And there's two pieces to this. So there's a foot piece and an ankle piece. And so when it comes to the Ottawa ankle rules, if you have any kind of tenderness in the posterior edge of the tip of the lateral malleolus or the medial malleolus, along with the inability to bear weight, you need to do an ankle film. If you have pain at the base of the fifth metatarsal or the navicular and the inability to walk more than 4 steps, you need a foot x-ray. So it's pretty straightforward. And I think it's kind of interesting, and this is an opinion, this is not a fact. However, I think the reason behind the weight bearing for the ankle fracture and the inability to walk 4 steps for the foot fracture is because when people have a foot fracture, they're going to preferentially walk on the outside part of their foot if they have a navicular fracture, or the inside of their foot if they have the fifth metatarsal fracture. I don't know if that's true. That's just a guess on my end. However, I think that when you can use a prediction rule like the Ottawa ankle rules, it's going to help exclude fracture in either 99% accuracy, something we can use on the field or in our office to help not necessarily save our patients money, but provide better care and not have to do unnecessary tests.
Yeah, and hopefully that's negative, whether it be the Ottawa ankle rules or the imaging is negative, meaning that we can manage this. And it depends on how badly that syndesmosis has been sprained. If it's a grade 1, meaning that there's just microscopic disruption, that's going to respond well. If it's a grade 2, where now we could see some of the rope fibers being frayed, that will take a little longer. And then a grade 3, we call that a diastasis, and that's a big deal. That's going to require surgical treatment. But most of these are going to be grade 1 or grade 2. And our treatment needs to be cautious initially, not to flare it up. We don't want to transition it to the next grade up. So those goals are to suppress pain and inflammation and swelling, but preserving joint mobility, because the patient doesn't want to do certain things. They lose joint mobility. And when the ankle doesn't move in all planes, we tend to then stress it. That's how repeat ankle sprains happen. these patients may need a brief period of non-weight bearing, that they don't want to stress that. If they're walking and when they go into toe off and their ankle goes into dorsiflexion and that wedge spreads the tibia and the fibula, if that's a problem, they need a brace. And that's not your standard ankle strap. Like the stirrup, that really prevents or minimizes inversion and eversion. That's not the biggest problem. It's dorsiflexion. So a boot may be needed for these patients. And keep in mind that these syndesmotic ankle sprains are going to heal much more slowly than their medial or lateral counterparts. It may require a period of treatment that's twice as long as what a grade 3, a rupture of a lateral ankle sprain. And 7 weeks is not uncommon for these patients. So be patient. And that starts with rehab, appropriate rehab. So Brandon, where do we start with that process?
Just like most things that we do, we need to calm things down before we build things back up. So isometric exercises are going to be a great way in the early phase to minimize that muscular atrophy because they're going to be in a boot. They're not going to be doing things as far as weight bearing. We can do other things that are used for anti-inflammatory purposes like ice, compression, elevation, anti-inflammatory modalities, any kind of medications, natural or unnatural, to make sure we can keep this person comfortable. But once they're able to bear weight, they're able to take a couple steps. This is when I'm going to start my rehab process to include the stretching, but also some light resistance exercises. The goal of this subacute phase is to restore pain-free range of motion. So that's the beginning piece. Now you can use cycling, you can use aquatic therapy if you have those things available, but really we can do a lot of open kinetic chain things, even like an ankle alphabet. And now once a person is able to achieve full range of motion, now we need to get into a stretching and strengthening program. I'm just going to give you what we have in ChiroUp. We do some stretching of the gastroc and soleus, obviously giving patients the videos of those. And then there's 3 things that we use for strengthening. So we need to strengthen the peroneals, the tibialis anterior, and we also need to train balance. So we do that through the resisted ankle dorsiflexion exercise, the resisted ankle plantar flexion exercise, and then also we use, as far as our standard, the wobble board exercise to help promote activity within all the muscles and promote balance. Now, if someone's having difficulty with that or any kind of pain, you can begin them with a single leg stance, then go to a Valais exercise, and then end up with the wobble board. It just kind of depends on where the patient is and where you need to meet them.
Yeah, this is one of those classic diagnoses that I personally don't see very often, that I'll see a few of these in a year's time. And so this is where I love to go back into ChiroUp to be able to dive in and say, what do I do for this? It's where I love to be able, in 4 clicks, deliver all of this rehab to the patient so that they can understand what's going on. So to summarize, a syndesmotic ankle sprain usually involves some sort of athletic injury, especially one that had dorsiflexion and hyperdorsiflexion and external rotation. It might look like other types of ankle sprain, but it's a little bit higher. It's just above the crease of the ankle. And the distance that it travels up is correlated to the severity of the injury. The higher up it goes, the worse the prognosis. We want to look for signs of avulsion fractures, especially on the tibia, and up to half of our patients who have a syndesmotic injury could have a coexistent avulsion fracture. So that's a traumatic injury that often has a bony consequence with it. And if we see those bones spread apart by more than 5 millimeters on a standing AP or an ankle mortise view, that's a diastasis. And that patient probably is going to require surgery to stabilize it because the cellophane is completely wrapped with little chance of it coming back on. And be patient. These are not going to heal quickly.
Yeah, great little wrap up there. So to wrap up the podcast, I want to talk about something that I do see, really every day. Has anyone in here ever gone through an entire day where someone's getting off your table and like, oh, I'm a little dizzy? I mean, that's a common thing that I hear as a chiropractor. So we do see a lot of BPPV, and I always use the protocol within ChiroUp. However, I will say one thing, is that some people have difficulty with the Epley maneuver and the Brandt-Daroff exercises because of the neck extension and the rolling maneuvers that people do go through. Now, that's not to take anything away from those treatments. They're obviously phenomenal. However, a new research article came out in March of 2024 saying the Sermont maneuver, which is also in ChiroUp, is also a standard option for treating posterior canal BPPV, which is the most common BPPV that we see. That's what we use Epley for. And it has a success rate around 80%. So this is a different maneuver that is straight going down and then coming straight back up and going down the other side, that does not involve those things that could be traumatic to a neck and a back. And interestingly enough, in the discussion part of this paper, it says individuals who complain of cervical lumbar spine problems can actually benefit from this maneuver. So this is kind of an interesting little piece that serves our demographic quite well.
So wait a minute, two things here. One, you have patients that have more than one problem coexistently. And two, we have an option for BPPV. One of the questions is, how many times do we perform those maneuvers? Well, there was a study on the Epley maneuver that highlighted the frequency. This came out in May of 2024, and it said that the success rates for these repositioning maneuvers is very high, especially in patients who have posterior canal BPPV, which is by far the most common. But the article states, quotes, however, more than a single maneuver is required in some resistant patients. Now remember, the success of this maneuver is 80 to 95%. That doesn't mean that it's going to happen on the first time. But doing this produces great outcomes. In fact, in our COP study, and if you haven't seen the clinical outcomes and patient satisfaction study, dive in and just Google ChiroUp COPS, and you'll see some interesting information about what you and our peers do to help patients. And you'll see that the single most responsive diagnosis is BPPV. The good news is easy to diagnose with the Dix-Hallpike maneuver and easy to treat with the Epley maneuver. You can also check out the blog. If you go into chiroup.com and go under resources to the blog, enter BPPV, you'll see a video demonstration of how to do the Dix-Hallpike maneuver, how to do the Epley maneuver, and you'll also be able to download the Epley guide. And one tip for BPPV before we wrap this up is that as barometric pressure falls, the rates of BPPV go up. So this is the time of year here in the fall. If you're listening to it right when we produced it, you're going to see more of that. And number two, it's very related to the patient's habitual sleep side. If they sleep on their right side, they're more likely to have right-sided BPPV. So giving them some ADL advice to maybe try sleeping on the opposite side, if they sleep on the side that's involved, would be helpful. In closing, we want to thank you for being listeners to this episode, for being subscribers to our product. If you enjoy listening to this podcast, I encourage you to hit that follow button so you don't miss out on any episode. And by following, you'll be the first to know when we release any new content, and you'll have access to our entire library of episodes. We're grateful to have you along for the ride. Together, we will make our profession the undeniable best choice for patients and payers alike.
Hey, thanks for listening. To access more information, visit chiroup.com. You can sign up for a 14-day trial. Use referral code PODCAST15 for a special discount after your trial. Offer valid on new subscriptions only.